Welcome to the Collective Unconscious Podcast. I'm Dr. Damian Tillman.
Hi, I'm Dr. Sheena Suchdev.
Welcome to our podcast. Today we have Dr. Kyle Faust on our show today. He is a clinical psychologist. He's currently at Home Base, which is part of the Massachusetts General Hospital. Home Base is a program dedicated to working with veterans, active duty service members, and their families struggling with the invisible wounds of war, such as PTSD, TBIs, and other anxiety disorders, depression, substance use disorders, and so on. He's also an instructor at Harvard Medical School and works as a consultant at Johns Hopkins Medical School at the Department of Neurology. In addition to working on research, the majority of his time at Home Base is spent providing treatment for PTSD for their intensive clinical program. So he is the person we want to talk about for PTSD. Welcome, Kyle.
Thank you. Thank you for having me, and glad to be the first guest here.
All right. Now, PTSD, do we know what that means, Doctor?
Yeah. So I'm happy to break down the different symptoms of PTSD. So PTSD stands for post-traumatic stress disorder. And the easiest way to think of it is that there's these 4 symptom clusters, and then someone also has to meet what's called criterion A. And criterion A involves experiencing some sort of traumatic event. And for all intents and purposes, a traumatic event would be defined as exposure to actual or threatened death, serious injury, or sexual violence. And someone has to either directly witness it happen or see it happen to someone else. And this could also include hearing about a traumatic event that happened to a close friend or relative. And this has to be a traumatic event that was violent or accidental if you're hearing about it happening to someone else. And then it can also include repeated or extreme exposure to negative details of the traumatic event or events, something like police officers repeatedly exposed to details of child abuse, things along those lines. And then moving to the 4 clusters of symptoms, the first cluster is what's called intrusive memories of the traumatic event or events. So that would be things like flashbacks, almost like you're watching a movie of the event occur. You might even feel like you're back there experiencing it again. It can also be these images of the event that you can't get out of your mind, not as detailed as a flashback, but this would be more like if I asked you to try to visualize a tree right now. You probably can do that even if you're not like seeing it like a movie screen. But these images are just something that you can't get out of your mind. You find yourself thinking about over and over again throughout the day. And then it can also include nightmares. So that's the first cluster. Then the second cluster is avoidance of things that remind a person of the trauma. So that can include using substances. It can be avoiding people, places, or things that remind you of these traumatic events. It can be staying really busy with work. There's many different types of avoidance. And then the third cluster of symptoms is what's called the cognitive and emotional symptoms. When I say cognitive, this means negative expectations about yourself, other people, or the world. Feeling like you can't trust anyone, everybody has bad intentions, things like that. And when I say emotional symptoms, that means strong negative emotions, feeling a sense of horror, sadness, shame. It can also include feeling detached from other people. And then the last cluster of symptoms is hypervigilance and emotional arousal. So the hypervigilance is where you're scanning your environment, you're frequently looking for threats. And the emotional arousal is where you have experiences like a exaggerated startle response, where loud noises really bother you, people coming up behind you really bothers you more so than average, substantially more so than average. And then because this hypervigilance and emotional arousal can be very difficult, it can lead to difficulties with sleep, anger, problems with concentration, and so on. So I know that's a long answer, but those are most of the symptoms. And then one other thing I should add, since it's important too, is that these symptoms have to last for at least a month. If it's any shorter than a month, we don't know yet if it's PTSD. And the vast majority of people that experience a trauma in the beginning show these types of symptoms. For a decent portion of people, the majority, in fact, eventually those symptoms will go away before a month is over. So, but there is a percentage that the symptoms remain, and that's when we start to see PTSD.
So what are you seeing as the most effective treatments for PTSD? And do they help individuals recover from the condition?
So there's a few different treatments out there that fortunately are known to be quite effective. And the most effective ones are either prolonged exposure or cognitive processing therapy. They're about equally as effective in treating PTSD. So they're considered the gold standards of PTSD treatment at this current point in time, at least when it comes to therapy. There's other approaches that are fairly effective as well, things like EMDR or cognitive behavioral therapy for PTSD. But the research really indicates at this time that the prolonged exposure, which is also PE, or the cognitive processing therapy, which is shortened to CPT, are the most effective. So both the PE and CPT primarily focus on reducing avoidance. When I was mentioning that cluster of symptoms earlier, the avoidance is that main focus because it's one of the major causes of PTSD. So by treating avoidance, the other symptoms of PTSD are typically also reduced. PE does this by a combination of two types of exposures. And the first is imaginal exposure, which involves a patient talking about their most traumatic memory repeatedly in the sessions. And although that's very difficult to do, it develops what's called habituation, which helps a person become desensitized, and eventually they're able to talk and think about the traumatic event while experiencing much less distress than they did previously. And then the second part of PE treatment involves what's called in vivo exposures. And these require developing a hierarchy of people, places, and things that a patient has been avoiding because these things remind them of the traumas. Few examples would be things like grocery stores, malls, concerts, and so on. And you would want to start with the easier ones and then work your way up to the more difficult ones. And you want to stay in those locations repeatedly for about 40 to 50 minutes each time, or stay there until the level of distress you're experiencing is reduced by about 50%. There's something called the SUDS, which is the subjective units of distress scale, which we use to try to measure a person's level of distress. If that goes down by 50%, you're on the right track. This also helps a person develop that habituation so that these places start to become much more comfortable with time. And then moving to the cognitive processing therapy, the second approach focuses on reducing avoidance and having a patient spend time processing their most traumatic event via writing exercises. But it also focuses on thoughts that have changed as a result of the traumatic events. And those altered thoughts are what are called stuck points, and they cause a person to get stuck in the symptoms of PTSD and just experiencing them over and over. By identifying and changing those thoughts, a person can become unstuck from the symptoms of PTSD and begin to reclaim various aspects of their lives. And although both of these treatments can be very challenging, the good part is they do tend to be very effective, and they're able to help the majority of patients in recovering from their symptoms of PTSD. As I mentioned, there's other treatments for PTSD that can also be effective besides therapy. Things like certain medications can help. Although the therapeutic outcomes are typically best with a combination of medication management and therapy. And then there's a few other novel treatments that are being worked on. Things like psychedelics might have some promise in treating PTSD, although they'll likely require some additional research to determine just how effective they are. And then there's also, as kind of a last thing, there's certain FDA-approved PTSD treatments out there, like FreeSpira, which is a new technology-based intervention that can also be effective.
Great. Now, I do want to drill down into those a little bit in a second, but I want to go back to like the symptoms and to the idea of a traumatic event. Typically, when we think about that, we think of like going to war or witnessing or experiencing an assault. What are some other kind of traumatic events that clients could deal with? And could it be anything? Could it be absolutely anything, or is there some sort of limit to them?
Yeah, so good question. If we're looking at criterion A, which is really the way of determining whether it's a traumatic event that could lead to PTSD, it's really broken down into those categories I mentioned earlier. So that would be exposure to actual or threatened death, serious injury, or sexual violence. And then you can either experience those events directly yourself or witness it happen to another person. You can also hear about traumatic events I described there that happen to a close friend or relative. And those events have to be violent or accidental if it's learning that it happened to another person. It doesn't necessarily have to be that way if it happened to you directly. And then that last one, that it can be experiencing repeated or extreme exposure to negative details of a traumatic event or events, like police officers being repeatedly exposed to details of child abuse, or anyone that has to pick up dead bodies. A number of these traumatic events are not necessarily related to war. And I think a lot of people sometimes have this misunderstanding that, oh, the only one who can have PTSD, the only person that can have PTSD is someone who served in combat. I hear that all the time with the patients I work with, even other veterans and active duty service members. Oh, well, I wasn't exposed to combat, so there's no way I can have PTSD. And as I mentioned, there's a number of other types of events that can be considered traumatic. So you don't have to just be in combat. You don't have to be a veteran or an active duty service member. These traumatic events can happen to anyone.
In your experience, do clients generally do they know they have PTSD, or is it something they kind of minimize or aren't aware of?
It varies a lot. Oftentimes, if they're coming into home base, especially for our intensive clinical program, they usually have at least some information on what's going on. Usually their family members are starting to notice how much they're struggling. And some of them have already tried to get help for PTSD and have had struggles finding effective treatment. So for some of them, they realize that they probably have it. But then there's other folks, especially some of the active duty service members, who have no idea what's going on. And they're struggling and suffering, but either they don't want to acknowledge that that's occurring, or they're not really sure what's going on at all. So there's a lot of times that people will come in, especially if family members have pushed them in, where they want to deny that they're really experiencing any problems. And especially for active duty service members and veterans, oftentimes there's this negative stigma about PTSD or any sort of mental health conditions, making them feel even more like they don't want to report these symptoms to other people. And sometimes they're in denial that they're even experiencing these symptoms.
Is it something? So what is the stigma? Is the stigma is that you're supposed to kind of suck it up and not kind of experience this?
Yeah, especially in the military. There's now things are fortunately starting to change, but there's still, especially for those who are in special forces, I think there's often a very negative stigma that can still exist. And there are definitely exceptions to that. Fortunately, the military has been doing a lot more to address these concerns because they realize how serious they are. But a lot of individuals can feel like, I can't report this. I'm going to lose my job if I bring it up. If I'm trying to share this with the therapist on base, that therapist is going to show these notes to everybody else. And so, yeah, there's a lot of negative thoughts about that. And then there's a lot of this perspective of, like, as you said, I just have to suck this up. I can deal with it. I have to be strong. Yeah, I'm weak. I don't want people to think I'm weak. I'm not a weak person. Only weak people have these symptoms. Yeah, these are sometimes the common.
I was curious, and I don't know if you would know the answer to this, but would anything in particular for a person predispose them to PTSD? And I'm asking that because I'm wondering, like, if there's a lot of people who see a battle and come back, why would some people have PTSD and some people wouldn't?
So it's a combination of things. First, it's a combination of the genetic predisposition. Certain people are genetically predisposed to have a higher likelihood of developing PTSD. So that's one factor. And then the environment can be another big factor. So if a person has already experienced traumas in their life, oftentimes that makes them more susceptible to future traumas. And that's an interesting one because some people would be like, oh, well, if they've already experienced traumas, then why would this impact them that way? But so like some people, maybe it can develop more resilience, but for others, it's like they've already been through so much. And then this just makes it even harder. It can sometimes be the straw that broke the camel's back, so to speak. And then on top of that, another big factor of the environment is the avoidance piece I was mentioning. The avoidance is something that's much more likely to lead to PTSD continuing. If somebody isn't avoiding, then there's a higher likelihood they'll be able to recover from PTSD on their own.
That's really interesting.
Mm-hmm.
Yeah, I mean, there used to be, I feel like back in like World War II, like when people came back from World War II, it was pretty common, like they just wouldn't talk about their experience at all. It's like off
Right.
limits. And I don't know if, does that mean they're avoiding it, or is that like they're finding their own ways to process it? I guess it'd be hard to speculate.
Yeah, it's a good question, because like in the older days, it was just called being shell shocked, so to speak. And I think that there's been examinations throughout history of symptoms of PTSD. I mean,